Hello, everybody. I love having a full room out there. How's the food? They always do good food here. Let me go over a few things. The raffle, we're going to start at 3:15, 3:20. So make sure you get it done. Make sure you put your name on it. The name part is on the back. All right? Raffle tag. The place to vote on your solutions is on the back of your map. This is all in your bag. Back of your map, circle them or go to the online survey. All right. Evaluation form is green. You don't have to fill out the evaluation, but we really appreciate it. And we try and make the changes you recommend. On the bottom of it is the CME, social work, and CSAC accreditation, continuing ed, but you have to go online to do the nursing. This is the first year we've had continuing nursing education. We're very excited, but you got to go online and do it through a separate link. So just go to the web page for the event and you can do that. If you need a certificate for CME, social work, or CSAC credit, you can have one. Just ask for it at the table, registration table. It's purple. But you don't need it. We'll send you something within a month. What did I forget to say? You know exactly where the bathrooms are. Dr. Green told you this morning. So I am going to tell you a little bit about, physician workforce update. We are not quite done this year. But we know there are 11,325 licensed physicians in Hawaii. And only 3,519 are practicing. 2,982 are almost 3,000 full-time equivalents. Not bad. We're up 115 from last year. We have seen a lot more locums physicians this year in all specialties, and that is new and unusual. We've also seen a lot of movement. We saw 212 decreased their work time, which often indicates retirement coming. But some of these were younger folks, and then 90 increased their work time. Only 59 retired, much less than last year, because maybe they retired last year. Unfortunately, 7 passed away and 84 moved away. There were about 20 who moved back last year. They moved away in the past and they came back. So that's good news. And then we found about 200 new doctors. We are not done with the demand estimates. We are trying to figure out what the number is for how many of psychiatrists we need in Hawaii. If you would like to help me figure out that number, let me know, because we have lots of different numbers and we can't figure out which is actually accurate because we know we don't have enough. So let me know. Similarly, if you would like to help confirm that I have all the doctors in your area in my database, just let me know. And I will get you the doctors' names in your area and you can say yes or no to them. Oh, the good news is we are getting younger. Last time I said we were 55 years old. Now we're only 53 years old. And for the first time, we are younger than the national average. So this is good news. 21% of our doctors are already 65. That used to be 22, so it's a little bit less. And women make up 40%, up from 38% last year. Our ethnic estimates are not perfect because we don't know everybody's ethnicities, but you can see them here. We want more than this non-diverse group. And so we're working hard at that. And Dr. Hedges mentioned that this morning, but we would like to represent our population with our physician population. Our largest shortages are listed here: child pulmonary, child endocrine, child GI, adult pulmonary, adult psychiatry, colorectal surgery, child psychiatry. Oh, because I don't have the clicker. I need the clicker. I've been watching the slides go just fine on my computer. I don't know what's wrong with you guys. Anyway, the shortages are very similar to last year, and we'll go back and go over that. I don't see the clicker anywhere. And let's see. So shortages are up from last year on all islands. Maui had the smallest increase, and the primary care shortage is about 200 statewide, so that's an improvement. But Honolulu County did not increase its primary care provider shortage. All right, I'll just tell you to advance. How about that? So this is a review for you. How many providers do we have? 3,500 for 3,000 FTEs. Okay, here's the estimate. Actually, this is an estimate. This is our current line of how many we have. Here's where we're getting younger. This is the best part. I feel younger already. Oops, you didn't see. Native Hawaiian 6%, Pacific Islander 2.5%. You can see there. Okay, here are the shortages. We can't find it. Oh, okay, that's really embarrassing. It was right in front of me. Okay, yeah. Okay, I am going to recover from this. Okay, so this is where we're getting younger again. Okay, here is our biggest shortages: child pulmonary, child endocrine, child GI, as well as child psych, and then adult pulmonary, psych, and colorectal surgery, allergy, and endocrinology. You've heard these all before, so I won't say any more, but the report will be public as soon as it's given to the legislature. And you can see Maui did the best as far as they didn't increase as much as the other places. And Oahu stayed the same for primary care shortage, but everybody else went up. Okay, so does everybody know how to fill out the answers to your solution list? No? All right, there's two ways to do it. You can just take your map and you can turn it over and you can circle 5 things, or you can go to the QR code on the map. Well, it's on both sides, and you can go and do that survey. Tell us what we should do first. The 5 things we should address first. So the most urgent, and you heard them talking about it this morning. So now, before I introduce our lunchtime speaker, I want to recognize somebody who, oh, shucks, I didn't even. I want to recognize somebody who was supposed to be with us. Pono Shim was supposed to be our lunchtime speaker, and he passed away this year. And he was going to talk to us about how to come together and work with love and compassion on this problem. And I miss him because I need that. His special talent and what he liked to teach people was another meaning of aloha. So I will let you hear from his words what he taught, but his special skill was to understand people and help them connect with each other. And you actually have this in a little card in your bag. You have the definition of aloha in his description. So reach in your bag, you can see this, take it home, put it up on your wall. I have a wonderful student who cut these all out. So thank you, George, wherever you are. Bless you. So I would like for you to hear this in your own words. Is it going to play if I push?
So today, commonly known as human on.
So
Aloha mai, aloha and welcome. What is aloha? What is this very special spirit that is universally spoken of? For some of us, it is more than a greeting. It's a life force that defines who we are and why we are here. I define aloha as a practitioner. It is my art form. I do practice martial arts. However, aloha is my art. And I say that because we're all familiar with Bruce Lee. And Bruce Lee was a great practitioner of Kung Fu. In fact, he called his Kung Fu Wing Chun. But when he describes his Kung Fu, he describes it as water. And he said that his whole objective was to develop a martial art that would flow just like water, that to every action, there was an opposite reaction that would flow very natural, just like water. And so he called his martial art water. For me, aloha is that water. That to every action, there is an aloha reaction. And I have this appreciation and practice of aloha, and it comes because of a kupuna that we have, and she was an aunt. And her name was Auntie Pilahi Paki, who passed away in 1985. And Auntie Pilahi was known as a keeper of the secrets of Hawaii. Many people say that she spoke a very deep, knowledgeable Hawaiian that had been lost, the knowledge of the secrets of this language and of our people. Auntie Pilahi was, to us, the proponent of aloha. She spoke of it in all reference and reverence as the answer to the solutions of our problems locally, statewide, and internationally. And prior to her passing away, she tasked us to be practitioners and never forget what aloha meant. Because in the 21st century, the world would be looking for it. In the 21st century, the world would be at risk. And the world would look for the solution, and this risk would threaten life itself and all world culture. And she said that the world, as they look for the solution, they would find the solution in Hawaii. And that solution was aloha. And so for years, many of us have been practicing. We've forgotten, we haven't practiced. But in this special time, all of a sudden, we're watching aloha emerge. And as this new restaurant opens in Corvallis, Oregon, it is an extension of that. It's timely. And so now it's time to share some of the deep meanings that are the aloha reactions for me. What is the aloha response? My interpretation of that word is a little bit different than most people have been taught, not because they're inaccurate, but because the meanings of the interpretations of the words that make up aloha were given in just a very special way. And so my interpretation of that word aloha falls down to 5 words, A-L-O-H-A. And the first word is akahai. The second word is lokahi. The third word is olu-olu. The fourth word is ha'a-ha'a. And the fifth word is ahonui. In all Hawaiian language, most of the words had 3 translations. There was the literal translation. And then there was what's called the kauna, or the symbolic translation. An example of that would be when we refer to pua, or flowers, and we were referring to children, the symbolism, or the kauna, the hidden message. And then there was the huna. The huna illustrations were the secret meanings of words. And so today I share with you the deeper meanings of that word aloha in the huna illustrations. The 5 words that make up aloha: akahai, lokahi, olu-olu, ha'a-ha'a, and ahonui. But what is aloha? What are those disciplines? Is the art that makes up the aloha? And so let's start with akahai. The literal translation for akahai is kindness. But the translation that she gave to me, the deep translation, was grace. And the picture or illustration is when you engage with white gloves to touch very cleanly. You don't smear, you don't leave your fingerprints. In other words, it's to respect and be very, very clean in our engagements. El lokahi, many folks interpret lokahi as unity. I was taught something different. I was taught means unbroken, connected, full, whole, complete. And the inference there is that we are all connected, and that we have to find those common connections so that we can come together. Olu olu, many refer to as pleasant. I understand olu olu as gentle. And the picture is that when I engage, I'm instructed to engage with very clean and soft, gentle touches, like touching a baby. To leave no bruises, to leave no stain, no fingerprints, with akahai and olu olu, to touch very, very gentle and lightly. Ha'a ha'a, a very special word in the Hawaiian language, commonly known as humility. I know ha'a ha'a as to go empty, to go to that place of emptiness. And in that place of emptiness, we have access to receive all which is there. And then ahonui, which is my favorite of the 5 words. Ahonui means patience, persistence, but I know ahonui as waiting for the moment. Because the moment is coming. And the moment might not come in my lifetime, but it will come. It's being prepared for the moment and preparing others for the moment. A continuous state of living in the moment and with the expectation and urgency that moments are coming, so preparing others for the moment. Those are the 5 words which make up aloha. And for me, just like Bruce Lee, to every action, there is an aloha reaction. When I speak of aloha, I'm not speaking again of the aloha spirit, but more as an art form, a practice. This is very pragmatic. It is not esoteric to me. It's actually extremely practical and a practice. And aloha is the hardest thing I do in my life. And it's the longest thing because it is a hard, hard discipline. Anyone who says aloha is easy and fast, I think does not understand the depth of this word, aloha. Aloha mai. Aloha.
Nope, no more. You can watch the full video there. Pono was an amazing man, inspirational. And in my time knowing him wasn't very long, but I said to him, my goal is to have everybody in Hawaii get access to care where they need it, when they need it, and I am failing. Our workforce shortage is greater and greater every year. And he said, Kelley, are you empty? Are you ready to listen? Are you really empty? Because the moment will come. You don't know when it's going to be, but it will come. So you must be receptive. You must be patient and you must be receptive. And then later I said, I'm really worried because I know we all need to work on this together, but there's a big trust issue. The providers are very angry at the big insurers and there's no real communication and there's no trust. And he said, Kelley, you need to base this all on connection. What is our connection to each other? And I said, well, we all want the patients to get excellent health care. And he said, yes, that is your connection. Build on that. So I'm very sorry he can't be here this year because he's a wonderful, inspiring speaker. And I miss him. But what I thought was maybe I can have someone help us connect to how helping the workforce shortage will help everybody. Will help the providers, will help the patients, will help the insurers, will help the legislators, will help everybody in Hawaii. And so this is a very different perspective, but I wanted Pono to be here with us today. Oh, you can't hear me. Oh, I'm sorry. Okay, thank you. Okay, so what was the last thing you heard? No, I'm just kidding. I was telling what Pono said when I said that I'm failing at this. He said, are you empty? Are you ready to listen? You just have to wait for the right time. And then when I said I was worried about the lack of trust between our insurance companies, our large insurance companies and our providers and kind of the anger that I've heard, he said, we need to connect. Connection is the answer. We need to connect with patients. We need to connect with each other. And that is how we will solve this. So now I'm going to introduce Len Nichols, who is a health economist extraordinaire. And I heard him speak for the first time, probably maybe 7 years ago. And I literally ran out of the room after him and stopped him before the escalator because I wanted him to come to Hawaii to talk to us here. So without any further ado, let me introduce Dr. Lynn Nichols.
So can you hear me in the back? Great. Well, Kelley, that was way too kind. And I love your memory because it was actually 107 years ago, but it was a conference in DC, and I think it was about 12 years ago, actually. Because I think I came, because this is my 4th time here. Yeah, which is good, y'all forgot. But I've been here 4 times. The first time I came, which is why I have the shorts on, and I apologize for the shorts. I swear Josh Green wore shorts the first time I came, and I thought it was okay to wear shorts in Hawaii. But the first time I came, I was bringing my teenage daughter and her little buddy. They were both into Lost, and Lost was being filmed here, and it was a big treat. And we had a 2-hour delay getting out of DC. Our luggage didn't make the connection in San Francisco. So I arrived here with 2-day-old clothes. So I went to an ABC store and bought a Hawaiian shirt. And turns out everybody else had a Hawaiian shirt on. So it was the perfect good day. So I swear somebody wore shorts that day, so I'll stand back here. But anyway, it is true. I am an economist. Some days that's okay. Some days it's not. You know, it's really true. I know you all have your own favorite jokes about economists, right? One is, well, he tried really hard, but he didn't have the personality to be an accountant. You know, another one is, this is my favorite because it's a t-shirt my wife got me, and it says economist, and it spells it out phonetically so you can pronounce it like a dictionary entry. And it says, someone who solves a problem you didn't know you had in a way you don't understand. Also see wizard, alchemist, magician. But I think my analytic favorite is one that's actually rings true all the time. And that is that an economist is someone who can see something happening perfectly clearly in real life and rush breathlessly back into their office to work out the math to see if it's possible that it actually happened. And that is the way we are. And we got to be that way because of the way we were training. We were trained that way in large part because of a book Adam Smith wrote called The Wealth of Nations, which is a good book and it's very good training. But I'll just say the thing about Pono and the thing about Aloha and the thing about being in Hawaii in shorts or not is you got to think beyond that one-dimensional economist. And turns out Adam Smith actually wrote another book, a book that some politicians and economists don't want you to read, and it's called The Theory of Moral Sentiments, where Adam Smith actually laid out why, yeah, markets work some of the time, but when they don't work, you better have rules. And those rules come from society, and those rules come from inside ourselves. Those rules come from an appreciation of aloha. So that may give you some little indication. I'm not really extraordinary, but I am weird because I believe that economists should be laced in moral grounding. And so I'll just tell you a little bit about my name. My name, Lynn, a lot of people think it's Leonard, short for Leonard. No, no, no. It is actually Lynn. That's all there is because I'm named after an ancestor of mine, a great uncle, who was the older brother of my grandfather. Their father died when my grandfather was 8 years old. And in Arkansas in 1900, there was no safety net. My grandfather went to work instead of going to the 4th grade. His brother, after whom I'm named, his brother was a high school senior. And the local Methodist minister, they were good Methodists, got him into college early if he would agree to be a Methodist preacher. So he grew up to be Louis Ebenezer Neal, Methodist minister extraordinaire. And they took Louis Ebenezer Neal and made Lynn. So you see, I was supposed to be a preacher to replace him. He died 6 months before I was born. So I've basically been disappointing my entire family my whole life, okay? But I promise today I will preach a little bit, because I do think you have to link the moral of economy with the real economy, and that's kind of what this is about. So let me just say, you may not know sort of what these words mean. Public good's kind of an unusual concept, but you probably have an instinct about what it means, and we'll talk about that as we go along. I want to talk a little bit about some of what we think we know. Kelley just laid those out. I'll skip over that. You know all this better than I did. I want to spend a fair bit of time talking about what economists mean by what is a public good, because I think it's highly relevant to the way you think about your workforce shortage situation. A little bit about the healthcare workforce as part of an ecosystem. As a number of folks said this morning, that is exactly the right, I would say, metaphor to think about it. And then in particular, spend some time who benefits and who should pay for trying to remedy the situation that you're in. And that's where I hope you will see a symmetry between what I'm going to say from an economic perspective and what Pono might have said from a philosophical perspective. I'll skip over this. These are 2 years old. That's what I could find before Kelley gave you the most recent numbers. You know of the reality. You've got very serious shortages across the board. I would also say it's not just you, it's everywhere in the United States, although yours are perhaps more acute than others, but everybody's going through these problems, and everybody realizes, the AHA included, the American Hospital Association, it's basically perceived that the staffing shortage is a #1 threat to patient safety that contributes to burnout and all the things we talked about this morning and all the things you've been talking about all day. And of course, the truth is, pandemic made all this much worse. So I won't belabor those points. You know this, you live this. And I'll just say, wow, what a nice picture. Isn't that a great picture? That's from the most recent report of, I believe, your hospital association. And I love the way everybody's smiling. And I'm not sure you can see this, and I'm not sure I can either. But what this is the chart that's in that report. And that chart shows you by profession. And by the way, MDs aren't on that page at all. It's all non-MDs. By profession in the healthcare sector, what's the percentage of positions that are unfilled? So if you will, the shortage. And then in particular, another column in there is turnover rate. All right. And the thing I added on the right, which you also cannot see, are the wages of these positions. And I'll just say, not to belabor the point, the lower the wage, the higher the shortage, the greater the shortage, and the higher the turnover rate. This is not shocking to anybody in America, but it is the reality. And let me just say, some of those wages, $17 an hour, $18 an hour, $13 an hour, all of them are lower than a living wage in Hawaii. And so what you have here is there's this genius economist at MIT, there are 4 or 5 of them floating around. The genius economist at MIT has come up with a way of measuring essentially a living wage depending upon the cost of living in your community. And he does it for states and communities and everything else. And I'll just say, what's interesting is a living wage obviously depends upon your household. It depends on the cost of living and your household. And what you can't see, and I apologize for that, I thought we'd have a little bit more precise graphics, but the bottom slides are about your workforce, what fraction of folks who have children under 18 in Hawaii who are married, what fraction of folks are not, and of those who are married with children under 18, how many have both working versus one working? And the reason that matters is because the living wage amount required depends upon your situation, right? And what you cannot see, if you're a single person with 2 kids in Hawaii, a living wage is $58 an hour. Okay, and we could go back to that hospital slide and you can see that most of the professions don't pay anything near that. So it's really a pretty serious problem. Now, what are the uniquely Hawaiian contributors to your situation? Well, obviously, as a number of the speakers, including Jim Winkler, spoke eloquently this morning, you've got a whole set of issues related to rural. And I love how the moderator kept talking about the rural pay differential, which has got to be addressed. But obviously, You've got greater provider shortages outside Oahu. You've got income, health status, social service lacunae out there. You don't have the same kind of telehealth capacity. Your cost of living, you may know, you may not. If you don't, here it is. You're #1 in the country. And your cost of living index, I don't know if you can see that, is almost twice. 100 is standard for the country. Hawaii is at 193. And for housing, you're at 315 compared to a standard of 100. And that is almost 100 points higher than California and almost 90 points higher than New York. You have the highest housing cost and the highest cost of living of anybody in the country. And as you learned this morning, you're paid less by Medicare than everybody else. So that's what you call in economics a problem, okay? And so you rank 47th in home ownership. So it's not the very bottom, but anyway, it's obviously not sustainable. So what are the costs when an economist thinks about how should we think about what it means to have workforce shortages? Obviously, we think your wait times are going to be longer for all kinds of care. You're going to have health outcomes that are worse because of all that. You're very likely going to exacerbate your already existing equity issues. Everybody's got equity issues. You're no different. Your health costs and prices are probably going to be higher because at the end of the day, especially in something like the nursing shortage, as it became more acute during the pandemic, you know, these visiting nurses and so forth, the wages that were paid to them were so high, it squeezed the margins of hospitals and makes them have to raise prices and all that sort of stuff. And there's no question burnout and mental health stress has been broader because of the shortages. And then there's no question the pandemic made all of this worse, absolutely cascading on each other. And finally, I would say, again, trying to take a step back to the total social perspective of a workforce shortage in healthcare. As people learn that 25% of independent practices are closing, as people learn that hospitals are cutting back departments and even services, as people learn that investments are not being made in clinics and so forth, then the rest of the economy says, ooh, do I really want to put a new business here? Do I really want to invest there? Do I really think this is a good environment? And your departure, your difficulty in retention that was discussed this morning is very much related to that. So now I want to switch gears a little bit and let's talk about, given all those facts, why do I think it's important to get you to think about this as a public good? Okay, what do economists mean by a public good? Well, there are two characteristics of a public good that are really relevant here. One is that multiple people can benefit from the public good simultaneously. It's what we call non-rivalrous. That is to say, I can consume it, you can consume it. Imagine sunshine. Everybody can benefit from sunshine, right? That's a pure public good. Well, similarly, if a healthcare system is working well, then the whole community is going to benefit from it. At the same time, it may be expensive or even impossible to prevent somebody else from benefiting from it. And once that's true, it's a pure public good. And that, in essence, defines the nature of what a public good is. And what I want to make clear before we get into examples, which we'll do in just a moment, is look at the fact that if you have a public good, it's very likely to make everything else worth more. All right, and to think about that, let's look at these examples. The first and simplest is national defense. If you don't have a safe environment, and you can say the same thing about police protection. Look at those countries in the world where order has broken down. Look at Haiti right now, or Ethiopia, where you have these struggles between warlords and so forth. In those environments, no one is safe. In those environments, everything is worth a heck of a lot less. Imagine a housing price in Haiti right now. So if you have a public good of protection, then it enhances the value of everything else in society. Well, go through here. Lighthouses. You can see how they benefit every boat. And you cannot prevent the light from a lighthouse protecting and guiding a boat in. You can do the same thing for streetlights. You see the idea. Parks, roads, dams, bridges, all those sorts of things are public goods. Their existence make everything else worth more. The problem is when you have a public good and you can't exclude someone from the lighthouse, you can't exclude someone from the national defense that's set up, right? Then it's difficult to make sure they're going to pay their fair share. And that's where we get into these situations. So there are degrees of public goodness I want to talk about, okay? And you want to think about rivalry, non-rival, exclusion, non-exclusion. And you see on the upper left-hand corner, that's private goods. That's things like ice cream, you know, medicine, food. On the right-hand side of the upper, you got it's non-rival, but it's excludable. Club goods, those are things like toll roads, right? A toll road is something where you could say you can only ride on this road if you pay the fee. All right, but I want to suggest that, you know what, you can turn something from a club good into a pure public good, the lower right-hand corner, by doing what? Taking away the fee. And policy can make something a pure public good, or policy can decide to make something more of a private good. Similarly, a look at natural resources. You could have a set of policies that said, you know what, the land is sacred, the minerals under this land are in the common held, or you can sell off oil leases and let individual companies make money off of it. Those are choices that you make. But you can use policy to move people back and forth between public or situations back and forth between pure public goods. But the fundamental point here is that some things are so non-rivalrous and non-exclusive, they tend to be public goods. And when we talk about public goods in general, we worry about what's called a free rider problem. It's a free rider problem because you can get the stuff without contributing to it. And a self-interested human being, rumor has it, will sometimes choose not to pay for public television or not to do that sort of thing. So there are degrees of benefits as well. Let's talk about flood protection. Now, you may know, maybe not, I can't remember where you said this. I now live in New Orleans. I grew up in Arkansas, and I now live in New Orleans. And so in New Orleans, let's just say the first thing you do when you move to New Orleans, other than learn how to talk a little slower, is you subscribe to the Weather Channel, because it kind of really matters, right? You get these hurricanes that come pretty much for 6 months of the year. And so we pay a lot of attention to flood protection, right? Now think about the benefit of flood protection. You build a levee or a firewall or some kind of thing. It clearly benefits everybody. So there's public goodness to it. But it benefits people with very nice houses very close to water a heck of a lot more than it does someone deeper inland, right? So there are different degrees of benefits. Think about vaccination, something we've all lived through. Clearly, a vaccination regime protects everybody, but it protects those people with particular immune deficiencies way more than the average fundamentally healthy 22-year-old, right? So at the end of the day, vaccinations, while they are public good-like, they have different levels of benefits to different people. Healthcare in general, right? When you think about it, healthcare, care delivered to a particular individual is actually a pretty private good, because it can be excluded, and it's something that goes to that one person, shot in the arm, whatever, for a cure. But when you think about the public part of the benefit gets bigger, the more you're talking about treating something that's contagious, or preventing something that's contagious, and even screening for something that's contagious is almost a pure public good, because you want everyone to know that you're at risk, and therefore you keep the rest of us safe. And my point is, each of these types of public goods will have different degrees of benefits and different degrees of publicness, but they all relate to the notion of more people gaining from it than any single one. Education. A lot of times you see examples, people talk about knowledge being a public good. And at some level that's true, right? Because once you write it, once it's in a book, in a library, in a journal that's freely accessible, then it is indeed available to all. But I'll just observe, and I don't mean to be overly political because there's not quite enough liquor in the room just yet, but I would just say, you know, knowledge is only a public good if people consume the knowledge. And if you choose not to consume the knowledge, then we're not exactly spreading it as far as you would like it. Think about the value of education by level of education. All right. Think about the difference between the public nature of the benefit to someone getting K through 6 education, elementary education, versus someone going to law school. Okay, now it's true there are some lawyers who are publicly oriented, but by and large, the benefit of that graduate education, maybe graduate economics, is going to be largely private. But the K through 6, even K through 12, that's going to be largely public. Why? Because we want every person we're in a society with to be able to read, to be able to follow directions, to be able to line up, to be able to, in essence, become members of society, and they learn all that in school, right? So public and private can be on a continuum. The public and private benefit from a particular element of a public good. Okay, let's take a little bit of a concrete example of differential benefits. Imagine fire protection. You got people, you got houses, you got businesses, and you have government. All of them are going to benefit from fire protection. What the different width in those arrows is meant to convey is that the value to each of them may be different. At the end of the day, right, fire is a threat to people, no question. And some level, you could imagine that benefit being defined to be infinite. Look at the energy and money we spend trying to save people from fires, right? But also, there's a lot of value tied up in people's homes and businesses, and those values are going to be threatened if there's a fire. And similarly, government, if the city burns down, then the government's value is gone to heck. So at the end of the day, there's tremendous value in all those sectors from having fire protection, which is why to pay for fire protection, typically, we take something from everybody, right? And at the end of the day, that's how we make it work. So economists often ask the question, why don't we have enough public goods? Why does it feel like we don't have enough parks, we don't have enough bridges, we don't have enough payment to infrastructure, et cetera? It's because of the free rider problem. And the free rider problem is present because it's impossible to exclude them from getting the benefit even if they don't pay. And so some people pay and some people don't. Exclusion is hard, and free riding is self-interested, and self-interested people will behave that way. So who benefits from a healthy health workforce? And notice, I'm not saying health care workforce, I'm saying health workforce, because I want it to be beyond health care. I want you to think about what makes people healthy. Who benefits from this? Well, obviously the population at large. If you have confidence that the system will be there for you when you need to go, even if you're not sick, that's a significant value. And obviously, if it's there when you are sick, it's a pretty significant value. Health organizations are going to benefit from a healthy workforce. Obviously, it makes hospitals, clinics, everything run. It enables them to earn revenue, et cetera. Health insurers benefit from having enough workforce. They don't have to take a chance on people not getting the care they need and ending up getting much more acute care later. Health workers themselves, obviously. Employers benefit knowing that that healthcare workforce is full and complete and there for the use when their employees need to. Governments, for all the same reasons. And you could even imagine philanthropies and certain kinds of civil society who have a compelling interest in maintaining a society's sustainability. They too would benefit from this workforce. And the point of this is to say, these are the different sectors, if you will, that benefit from a healthcare workforce. And therefore, these are the ones that bear the cost when the healthcare workforce is not complete. So here's some what I call good Hawaiian facts, and then one implication that I draw. The good facts are when you compare Hawaii to the rest of the country, and I know there's lots of ways you could do this, But the simplest kind of bottom line way is life expectancy. And what's interesting, when you just look at it from the outside, your life expectancy is #1 in the country. Now, like everybody else in the country, it's fallen a little bit through COVID. No question about that. Last couple of years have been rough on everybody, but you're still #1. Now, I don't want to paint a Pollyanna picture, because you do have the same kinds of disparities that exist elsewhere in the country. Every island has about a 12-year gap between the highest and the lowest. But on average, you're doing amazingly well. All right. #2, this may be less well known. When you look at your private insurance premiums, you're the second lowest in the country. Second lowest in the country. You're 11% below average in the United States. Now let's back this up and remember, you've got twice as high a cost of living, 3 times as high a cost of housing. You got the highest life expectancy in the country, and you're paying less for premiums. And Jim already told us Medicare pays you less. So there is something to this notion that there's a tremendous value being delivered to the Hawaiian society from your healthcare workforce that is not being paid for. And that's really what my inference is here. If we can get this to click one more time. The society of Hawaii has been getting an unfunded benefit, an unfunded value, I would say a consumer surplus that's not being paid for. And in a way, the cost is becoming more clear. So how would I describe it? Well, let's go back to people, insurers, employers, government. Here's the value they're getting. Here's what they're paying. And this is the consequence. And I hope you can see those pictures. Now, those pictures, of course, were taken in the last couple of years. I don't know that any of them are specific to Hawaii, although the top one looks like it might be. And the point is, the healthcare workforce is so completely overwhelmed, so completely burdened. You know the statistics on burnout better than I do. And I submit to you, as a simple country health economist that I am, it has to do with the imbalance in those arrows width, the value delivered and payment received. And that gap is fundamentally the source of your health workforce shortage. So here's some not so good Hawaiian facts, because you might say, well, let's just spend more money, and it's possible we can do that, and we may need to. In fact, I think you do. But don't just assume you can just, raise taxes. You have the third highest tax burden in the United States, as measured by the tax foundation of the country. And I'll just say you're at 14.1% of basically total income. And that's all taxes, state and local, okay? And New York's #1, Connecticut's #2. I will say you have a higher than average, what they call sales excise tax. You have a pretty high sort of sales tax type stuff, excise tax type stuff. And you have lower than average income tax receipts, and you have lower than average local property as well. All those were surprising to me, but then I don't know much about the world. I'll just say that's the situation. That implies it's probably not going to be completely solvable just by having government come in and do more, although we can all hope Josh Green will have success in accomplishing that. So what are the solutions to the free rider problems as they've arisen over the years? And they've been present ever since we've had a market economy, right? And the classical solution, you can pick up any economics textbook, and the first solution will be government, right? And it's perfectly natural for government to be considered to be the solution, because if you cannot exclude people from a benefit, and think about raising money for public television or local parks, you're never going to get enough. And government has to supplement it in order to get the scale up to where you think you need. And for things like national defense and police and fire and so forth, that's largely what happens. Now, government doesn't just make money out of thin air. Government has to tax some people. So government has to decide first, what's the scale of public good we need? And second, what's the scale of taxes that my population will support that I can divert to that public good? All right. And I'll just observe that's a natural solution. It's used for lots of things, but you might have noticed this. A lot of people around the country have sort of lost faith in government's ability to be completely wonderful at picking the level of public good and the level of taxation. And because of that lack of faith in government, we kind of are in the situation we're in. And that is, we don't have enough of this stuff. And you're kind of stuck in this situation. All right. So what do? Well, turns out economists never quit trying to figure out a way to solve a problem that you don't understand. And there was a solution to this constructed in the 1970s. Right? And the solution is now called Vickrey Clark Groves. I won't go into detail. I'll just say it's a way for individuals to do that wonderfully Hawaiian thing of coming together and solving the problem collaboratively. It has to do with, first, they have to agree there's a problem. They have to agree how big the problem is. Second, they have to agree to essentially abide by a set of rules. Go back to Adam Smith and the need to have rules in society. Abide by a set of rules about how each person's price will be set. And they have to agree to that before we start talking about how much to pay. They agree upon the rules and agree upon a structure, you can solve the problem this way. Now, this is now taught in game theory classes in very arcane corners of engineering and economics. It's almost forgotten. And what happened was a very brilliant young co-author, now co-author of mine, I didn't know her at the time, gave a talk. And her talk was so impressive at a conference, not unlike this, that I came up to her about 6 years ago and I said, wow, that was so impressive. If you will teach me all this stuff, this social determinant stuff. She was talking about social determinants and why we don't have enough social determinants expenditures. And I saw instantly it was a public good problem. I said, if you will teach me social determinants, I will find us an economic model to incentivize investment in this public good. I was bullshitting. I had no idea what I was going to do. I was just saying, you know, this is a really great talk. She did her job in a month. It took me a year. But turns out this stuff is embedded in 1970s game theory. Can you see my gray beard? I went to grad school in the 1970s. I can still read that shit. I was amazed. And the point is, there is a private sector solution to a free rider problem, but it requires a particular set of rules. Well, what Lauren Taylor, and I'll show you a little bit more about her in a minute, what Lauren Taylor and I then did was we modified that 1970s model and brought it into today, and that's what CAPGE is down there in the left lower hand corner. And it's now in place in Cleveland, in Waco, Texas, and in Albany, New York, and we think it'll be in DC and maybe Annapolis, Maryland next year. And the whole point is how to bring people together to work collaboratively, to agree upon a set of prices that they all think is fair, and that makes it sustainable over the long haul. The point is there are ways to solve the free rider problem that do not require government to just write a check and go out and earn the trust of the people, because I'm old. I can't wait for people to retrust government. I want to solve these problems now. The other two entries down there, common spirit. How many of you heard of common spirit? Interesting. Common Spirit is the current name. I know they keep changing their name. They used to be Catholic Healthcare West, and then they became Dignity, and now it's Common Spirit. Next week it'll be something else. But the point is, they are doing the Lord's work, literally, arranging communities to come together and try to solve these problems collaboratively. They have a sort of a different version of this solution than Lauren Taylor and I do. And the final notion there is co-opetition. Co-opetition is a concept that basically is about this. What if you say, okay, look, you know, no individual is big enough. No individual can solve this problem. No individual health insurer can solve this problem. No individual hospital. Together they could. What if they co-opt, that is to say, agree not to compete upstream, but compete downstream, and upstream they collaborate and do things like invest in infrastructure, do things like invest in information infrastructures that can enable your team-based work to come into being, to enable you to communicate with social workers doing social services that are absolutely essential to managing people's health, right? And so those kinds of infrastructure upstream investments can be done collaboratively, and then you compete just like you always competed for employers and everybody else downstream. So those three different types of solutions exist. You can look for the literature and there, you'll get these slides and all that stuff. Let me just say a word about Lauren Taylor, more about my co-author, because she's so amazing. Lauren is now an assistant professor at NYU Medical School, but when I met her at this conference, she was just starting her PhD program at Harvard, and she was in the healthcare policy program in the medical school, which was invented by a health economist, Joe Newhouse, who will someday win a Nobel Prize. But Joe basically thought it would be a good idea if doctors learned health policy, hence the name of the program, and if policy people learned clinical facts so they could understand the clinical world better. And that's what the healthcare policy PhD is about. So Lauren was starting that program, but Lauren, before that, an undergraduate at Yale, she was the undergraduate research assistant to Elizabeth Bradley. Any of you heard of Elizabeth Bradley? She's now the president of Vassar, but when she was at Yale, she's the woman who figured out that countries that spend more on social services spend less on health. Kind of a big deal. And she figured out, Betsy did, how smart Lauren was, got Lauren an MPH in 1 year. And then, uncharacteristically for an Ivy Leaguer, Lauren's boyfriend gets drafted by the Kansas City Chiefs. He had played fullback for Yale. He was both big and fast. So she goes to Kansas City. She spends 2 years pretending to be an NFL wife while she edits Betsy's book, which became American Healthcare Paradox. She did such a good job editing it, Betsy made her co-author. So Lauren had a book at 24. Then Shane gets cut, but he lasted 2 years more than me in the NFL, so I'm impressed. He comes back to Yale, and like all good Yale boys, he goes to Wall Street, he's making lots of money. Lauren wants to change the world. She goes to Harvard Divinity School. She finishes Harvard Divinity School. She can marry you and bury you, but it turns out when you finish Harvard Divinity School, there are no jobs. They're not connected to a church of any kind. They just send them off into the world to do good. So Lauren looked around, what do I want to do? What she cares about is health policy. So that's how she got in Newhouse's program for healthcare policy. Her first year is when I saw her give that talk. So I said, you do that, she did that, we wrote a paper. Usually when you write a paper with economic content like this, you get like 4 emails, right? In my age, the first one's always, Lynn, it's time to retire. And the second one was, hey, you know, you should have used this other data set or this other mathematical proof. I mean, come on. This time, we had 20 communities around the country call us up and say, can we do this here? Now, it's a clever paper. It's not that clever, okay? Here's the thing. There's this hunger. There's a real hunger for reaching upstream of the healthcare system. Why? Because y'all have all figured out. You've all figured out you want to solve people's health problems. You've got to integrate that with solving their social problems. You got to integrate that with getting them food, making sure they have someone to talk to, making sure they have access to everything they need, housing, et cetera. Okay, so there's this huge hunger for that. And that led to this incredible demand. And that's why I'm so excited. I don't know if you can tell. It's why I'm so excited to be doing this work right now. Because right now is when we need to collaborate. Pono is right. We don't know when it's coming, okay? But it's got to come. Because if it doesn't come, we're not going to make it. It's got to come. And when it comes, we're going to be collaborating and not competing with each other. So we made this little model. It's called CAPGE. You can look it up and click on it and all that stuff. This is the article I wrote with Stuart Butler, who was at Heritage. As he puts it, Heritage didn't leave him. I mean, he didn't leave Heritage. Heritage left him. Heritage moved far right. Stuart stayed exactly where he was. 30 years ago, Stuart and I debated health reform probably every other week in DC for fun and profit, okay? Now, he agrees with me completely. We should have had the ACA. We ought to do social determinants. I consider that personal growth on his part. But the truth is, what's happened is he's come to see, and I've come to see, you're not going to solve these problems unless you solve them in a bipartisan way, and it has to be that way to be sustainable. Okay, so Stuart and I wrote a paper about co-opetition. Anyway, the point is, if we just sit back and don't collaborate and let the healthcare system fend for itself, okay, here's what's going to happen. There's no way around it. Every price you pay is going to rise. There's going to be a crisis. And when the crisis comes, you're going to have to pay the price of no one's going to be there to treat you when you want to treat it. The thing about the rural differential, just as a country boy who grew up in a town of 2,000 people with no hospital and one doc, and when he died my sophomore year in college, they still don't have a doc in that town. Okay, you've got to think about, what do we really want our society to be if you don't have healthcare in rural America? You're not going to have rural America. And I don't know about you, but I'm pretty sure part of what makes Hawaii attractive as a tourist destination is precisely its rurality outside of Honolulu. So you kind of got a strong interest in doing that. Okay, here's the thing. Yes, the crisis will happen. The free riders won't pay directly, but they will suffer what we call a growing opportunity cost, what they could have had if they had built the right healthcare system. In essence, your choices are to continue down an individualistic path, in essence, playing king of the mountain on the left. Or you can come together in tables not unlike these and try to collaborate and find a solution. Now, what are the elements of collaboration? What will make this work? Well, first, you got to agree on the facts. You know, Senator Moynihan was pretty famous for a long time in Congress, was saying, everyone's entitled to their own opinions, but not their own facts. And today in DC, that's not so widely accepted, which is why, it's a secret now, I want you to pay attention, the solution ain't going to come from DC. The solution is here. You can tell them about it after you're done, but you've got to fix it yourself. Okay, so what do you got to do? You got to agree upon the facts. You got to define and measure the cost which stakeholders bear now for the health workforce shortage. As I tried to say, and as I truly believe, although I could be persuaded otherwise, but right now what I believe is some people are getting a hell of a bargain here and not paying their fair share. And that's why you're straining around the edges and in the middle, and therefore about to fall. So figure out what the cost you're bearing now, and that cost estimate of what you're bearing now is the lower bound estimate of the value of fixing the problem, the lower bound estimate of the value of having a healthcare workforce that's adequate and sustainable. It's going to vary by stakeholder, of course. You're going to estimate the cost of remedying the workforce shortage. And I mean, I've been to, what, 3 sessions this morning? I've floated around. There's 100 solutions. Kelley's got a matrix that's about the biggest matrix I've seen since I learned Fortran 140 years ago. I mean, you know, it's, oh my God, Kelley is like, there's lots of solutions. Probably all of them are necessary, and none of them are sufficient unless you sort of start today. So estimate the cost of remedying this stuff. Payment rates are going to have to go up. I'll say that out loud if you don't want me to, but I will. Payment rates are going to have to go up. Wages for some folks are going to have to go up. No question about that. And probably going to have to subsidize certain things. And probably you're going to have to figure out premium increases as well. But I'll just notice what this is really about. It's about shifting priorities. And I just did some back of the envelope math just for fun, because you know we can do that. You could take 1% of the medical loss ratio of one of your insurers and dedicate it to primary care and give every primary care doc in Hawaii $29,000 more in income. Now, that's not sufficient. There's PC, you know, and NPs and PAs and all, there's all that complicated, lots of details to work out. I'm just trying to say, move your perspective into how you think about where the money could come from and be open-minded about the possibilities. I can't read it. Increase. Oh, yeah, okay. Yeah, obviously, you're going to have to increase the workforce pipeline. There's a wonderful session earlier this morning about the workforce pipeline and substance use disorder. There's lots of different things. Y'all got all that underway. I'm just going to get out of the way. I'll just say that's really important. I would encourage you. I know a guy in Virginia thinks about this a lot. Pipelines is one thing to think about. Another way to think about it is highways. Because what I mean is, instead of saying, okay, we want you to grow up and be an MA, we want you to grow up and be a healthcare worker. You might be an MA along the way and become something else. We heard about that this morning, right? So we want to think about highways, allow people to flourish and find alternatives, but get them on the direction where you need them to be. Oh, new housing, okay? Look, there is no way to solve your workforce problems without addressing housing. Now, we have a session with a really smart health economist, Bianca Frogner, and I, in about, I don't know, 45 minutes or something down the hall, where we're going to talk about housing specifically. But I'll just say, with housing costs 3 times the national average and lower payment rates than anybody else, there's a term for this in economics. It's called stupid. This cannot work, okay? This is not gonna, this is nothing you can do. So you're gonna have to build some houses. Now, there's lots of alternatives. We'll talk about where and how and so forth. There's hope. There are people out there who have done this. You know, I mean, it's not rocket science. It's not even hard economics. You don't have enough of this. You need more. Okay, what do? Well, you know, you be creative. You are all too young to know, but back in the 80s, there was a housing crisis for the first time, really, in the United States, in California. Housing prices just took off. It took off as a result of a couple things. They'd had migration forever. It was really the property tax cap from Proposition 13. Some of you may remember that, reading about it in college or whatever. And that was a big deal in the tax revolt. But it had the effect of basically overnight driving housing prices up. Well, it turns out faculty at Stanford couldn't afford houses. And that was unacceptable. And so Stanford, having an endowment, said, well, we can fix this. We'll just basically loan money to the faculty so that they can buy a house, maybe pay 60%, and the university would pay 40%, and the university would loan them the money for the mortgage. Think about that for just a minute. It's called shared equity. Think about it from the university's point of view. You got a tenured professor here, he ain't going anywhere. His credit rating's pretty good. He's going to get paid. You're paying him. And you can make money off real estate while you're doing it. It took Stanford about an hour and a half to figure out this is a good idea. I was teaching at Wellesley College in Massachusetts at the time. When I got tenure at Wellesley in 1987, I took my little pay stub down to a real estate agent. He plugged it in the computer. There was exactly one house I could afford, and it was 6 feet from a prison. Okay, so we were in the same position as they were in California. So I talked Wellesley into mimicking Stanford's deal. Then I went on sabbatical, got caught up in the Clinton health reform, never got a dime out of Wellesley, but it was a great gift. But anyway, my point is, there are creative ways to do this. And if you think about it for another 30, 45 seconds, you don't have to be a university to pull this off. Regular banks can gain by doing something like this. And I would just submit, y'all gonna have to do some serious housing business if you really want to address your workforce shortage, especially when you go back to that hospital association chart with all those non-physician categories where what would you tell me, Kelley? A living wage in Oahu on average is like $94,000, $84,000 or something. Give them housing. Okay, so yeah, here's the big thing. Whether you do our model, CAPCHI, Common Spirits model, co-opetition, whatever model you choose to try to pursue to do collaboration to finance your health workforce shortage remedy, you're going to need to have a group. Apparently, y'all are pretty good at making groups, okay? So think about a group. Who should be in the room? You had them, a lot of them on the stage this morning, but I would submit you also want employers, big employers, small employers in that group. You also want banks in that group, people who have a deep stake in the community. You want community members. Hey, what a concept. Real people who live here. You want that group to represent the whole society, and that group could be constructed lots of ways. I've been trying to bend Jim and Kathy's ear. I think it should be a little kitchen cabinet for the new governor, whoever it is, right? But you could make it formal, make it public, whatever you want to do. But that group has to be able to establish these facts, establish the pathways to remedies, and establish the alternative ways to finance them, right? You got to determine your priority targets and your priority actions. Sorry, I just can't read it. Oh yeah, okay. So you got to figure out who's going to benefit from remedying these shortages, and in a sense, what's the value stream flowing to them from doing so, and therefore implicitly, what should they be expected to pay? You're going to assign fair prices. The way those collaborative models work to solve the public good problem. Okay, let's take just a second, think about how does government solve the public good problem? Government solves the public good problem by declaring we're going to have this bridge, and we're going to tax the following people to pay for the bridge, or we're going to set up a toll, whatever. Government, in essence, allocates what it perceives to be fair, which is the same thing as what will my citizens tolerate? What will they pay and not revolt, okay? And vote me out of office or whatever. Well, similarly, if you have a collaborative arrangement that does not rely on government, government's going to be part of the solution. Government's one of those stakeholders sitting around the table. In fact, I would argue a couple different parts of government are there. Your Medicaid agency, obviously. Your Department of Health, obviously. But also, your insurance regulators got to be there. Kelley talked about trust at the beginning of our luncheon session. I think it's fair to say everything in the social collaboration sphere moves at the speed of trust, but trust does not move fast. And from what I can tell, trust has been lost. I think those were her words, not mine. And because it's been lost, it's got to be reestablished. And by that, I mean, you got to have people who believe the numbers that are observable in real life. And that's going to